Thank you very much for the kind invitation to come and talk to you at your Divi Day, and also the support that many of you on this call have offered us already. So I'm clinical lead for endoscopists and a consultant gastroenterologist during the day. At night, I'm a kitchen ODP to one of the paediatric anaesthetists at NUH. So I'm just going to give you a whistle-stop tour of endoscopy and some impact from anaesthesia. And the short answer to the question is yes. Obviously, can anaesthetists improve quality and safety in endoscopy? So I'm hoping to give you an overview of NUH endoscopy for those that aren't familiar with it. Why do we consider deep sedation or general anaesthetic in patients undergoing endoscopy? Thinking about the clinical and safety outcomes, presenting some data from Europe where this is being used more widely, as well as Australia, and thinking about the logistics at NUH and some of the future options that are going to be open to us, both in terms of service and training. I've just come back from the Isle of Wight Festival, had a lovely sunny weekend, and I think Florence does know best, and this is one of her songs called Free. I wonder if I should be slightly medicated or feel better, just lightly sedated. I think some of us feel like that when we're just back from holiday, but certainly our patients tolerate endoscopy better. And things like the gag reflex do come faster than unexpected, and they're one of the things that really impact patient tolerance. When you see patients after endoscopy or indeed any procedure, the two things that have an impact on tolerance is their peak experience and their final experience, whether that is good or bad. So adequate sedation, whether it's conscious or deep sedation, if that can temper those feelings and improve them, it certainly improves patient satisfaction and outcome. So thinking about NUH, where do we add value? I think there's a lot of endoscopy that can be done, but I think a lot of it may not add a great deal of value. And what I'm interested in is where we can really add value with endoscopy. And there's obviously a broad range from screening and early detection of disease. You'll be aware of things like Barrett's surveillance or the bowel cancer screening program in people who've had a positive fecal immunochemical test. And there's a lot of bowel cancer screening activity at NUH. We obviously investigate symptoms, and we biopsy for and stage for patients undergoing cancer investigations. Increasingly, minimally invasive polyp resections from the lumen of the bowel, both upper and lower GI, areas in the gut. And we often use step-up treatment with endoscopy as the first treatment. We know that surgery now for things like peptic ulcer disease is really very rare. And things like managing peripancreatic fluid collections, such as pseudocysts or walled-off necrosis, also now start with endoscopy drainage before moving to interventional radiology or surgery. And most of you will have had some experience with the emergency management of GI bleeding or patients perhaps with bowel obstruction requiring luminal stenting. So what do we get up to in Nottingham? This is our link to our website, and we perform around 20 to 25,000 endoscopies each year, split half and half between lower GI with colonoscopy and sigmoidoscopy, and upper GI together with HPB endoscopy with endoscopic ultrasound and ERCP. And of course, respiratory endoscopy is an important component of the service, mainly over at the City campus, where they perform around 1,000 bronchoscopies, endobronchial ultrasound and thoracoscopy. What about our current capacity for deep sedation or general anaesthetic? At the moment, we have around 300 lists at Queen's, mostly now focused in Theatre 14, used to be those over at the treatment centre. On Tuesday, we mainly focused on EUS ERCP. Wednesday, lower GI resections with endoscopic mucosal resection or endoscopic submucosal dissection, so EMR or ESD. And on Friday, there's a mixed list of patients who may not tolerate endoscopy under standard conscious sedation, learning difficulties, previous failed sedation for less invasive procedures. At the City, there's an upper GI list, around 48 lists a year, focusing mainly on upper GI resection. And Steve's led the respiratory endoscopy list within City Endoscopy, which he's going to talk about a bit later. And again, we access through the whiteboard and emergency listing at both sites for patients with urgent problems, principally GI bleeding, either on acute admissions or those on the wards. In terms of accessing anaesthesia or deep sedation in endoscopy in Nottingham, it's probably only around 3% of all endoscopy, and that has increased significantly over the last 3 or 4 years, really taking an opportunity from COVID and supported by Simon Hardwick and his team over at the treatment centre theatres, and initially set up with Dave Evans and Andy Dyson, and Andy's now retired. There's been several other anaesthetists who've supported us in this development, and that's with around 400 lower GI, around 600 upper GI resections and radiofrequency ablation of Barrett segments. On the acute service, around 400 acute GI bleeds, 1,000 EOS ERCP, and Steve's going to present his data on bronchoscopy. So that is an increase and an escalation from pre-COVID. And we know that both diagnostic and therapeutic endoscopy are increasing year on year within the UK, and that's reflected also in Nottingham. And in certain areas, there's been a shift in the approach. We try and avoid riskier procedures for safer procedures. And you can see from this graph the amount of ERCP that we do that carries risks of pancreatitis, perforation, aspiration is reduced from around 1,000 to 600. And endoscopic ultrasound or combined procedures have increased over the last 10 years. And this is because if someone's had symptoms that have settled or the liver chemistry settled and they've had an MRCP that's shown a bile duct stone 6 weeks ago, we can do a quick check with a low risk endoscopic ultrasound to see if the stone's still present before proceeding to ERCP if the stone is present. And also we can stage and sample pancreatic cancers with endoscopic ultrasound and then proceed to stenting in the same session with ERCP. So why should we think about deep sedation or GA for endoscopy patients? Well, I think it's really, I think all of us would like to maximize safety and success in endoscopy. And although we know that most of what we do tries to add value and is good for patients, there is that risk of complications. And what we want to avoid is a situation where you have more complications than benefit that you're delivering to the patients. And I think using deep sedation or anaesthesia appropriately really fits in part of that safety envelope. So what are the most common reasons why we would fail at endoscopy? Well, this is often predictable sedation issues, and it really raises the question whether you should have to fail a conscious sedation procedure before accessing GA or deep sedation. And I think some of these are predictable, and we should be triaging and pre-assessing patients straight to deep sedation or GA if there's a high chance of treatment failure. And this is often younger patients who may be on concomitant drugs or have IV drug abuse with high use of opiates. They may have failed prior procedures. I think endoscopy is taking on more complex cases, as I mentioned, stepping up and avoiding the need for surgery. Some of these take a longer period of time, and conscious sedation can be difficult for those patients to tolerate. And again, it can reduce your treatment success. And there's been a lot of work looking at reasons for failure, and a high proportion of all those studies show failure of conscious sedation as one of the main reasons. Obviously, we're a teaching hospital, and if we're training, that can sometimes extend the duration of the procedure and contribute to failure at endoscopy. And this isn't just the patient, this may also be the operator. Certainly discomfort or blind panic it's a lot nicer to do a procedure that may be complex with the support of anaesthetists or AA supporting us in these cases. And I guess this is on the background of a coroner's inquest that was quite high profile at the time, initially centred around the same doctor, which was one of our trainees. We only have 1 or 2 ERCP trainees at any one time, so inevitably he will be associated with their successes or their complications. And the trainee, I'm glad to say, was totally exonerated in his training competency and his supervision, but there was a PFD that gave us some food for thought, and has really been a lever to try and improve safety, not only in ERCP, but in other aspects of endoscopy in Nottingham. So improving vetting and validation, trying to come to a personalised consent and risk assessment, which to my mind isn't just the procedure, but is also linked in with the type of sedation or anaesthetic that you may be delivering. As I've alluded to, developing further our combined EOS ERCP service, and there's now no one in Nottingham who does ERCP that doesn't also do endoscopic ultrasound, and improving access to anaesthetic support. So just in a broad terms, I think we've gone along this sort of journey in GI management, from just knowing about something when they've finally died, surgery, endoscopy intervention, interventional radiology, and now interventional endoscopic ultrasound is taking a lot of the work that was previously done by IR and surgery. And the final step in evolution for those, it's obvious, we've now got many GI trainees who are women, and that's including in interventional endoscopy. And there's a supporting women in gastroenterology program, which is really active in the UK, I'm pleased to say. So our key principles, I think, is to make sure we've got adequate pre-assessment, and Dave Evans and Avchana really helped to set up access to pre-assessment on both campuses, on B50 and at the City. So before patients are coming for their procedure, they've had their stop bang check. I've just realised that I do snore sometimes. I'm over 50 and I'm male, so my score's 3, which gives me an intermediate risk of OSA. But that's important to identify other problems such as anticoagulation or comorbid conditions that can help us with personalising consent to the best of our ability. And I think managing expectations with the patient so that they get the right sedation choice for the patient and procedure. If we tell them they're coming for a GA, trying to talk them down to a propofol sedation case with the anaesthetic assessment on the morning can be difficult. So that's one of the things I've learned from helping develop this service. I think after the Montgomery case that you'll probably be aware of, we've really changed in the way that we approach treatment. And I think obviously patient autonomy, being aware of options for them, alternatives, including doing nothing, is becoming more prevalent in the way we make decisions for our patients, rightly so. Thinking about some clinical and safety outcomes, we know that we want to try and avoid doing things that are futile. And the NCPOD report in 2004 around endoscopy was really quite critical of doing procedures where there was a high level of futility. And in the sedation cases, around 8% of those patients had the need for reversals with naloxone or flumazenil, which are never events in our trusts and now happen much less commonly. And I think our practice of sedation has improved, and we're grateful to Henry Skinner and Nehar Sandhu, who are doing the sedation leading and training within endoscopy, as well as many other departments in the trust. I think in my career, I've probably done around 12 to 15,000 endoscopies, and probably 80% of those have used conscious sedation, mostly with midazolam and flumazenil. But a lot of our sedation audits have just emphasized understanding the risks of oversedation and careful titration and adequate initial starting doses and scaling those up according to patient characteristics and age. So this was one of the largest studies from Germany published in the BMJ called the PROCED2 study. It looked at propofol in diagnostic endoscopy with a range of different drugs, but most of these were using propofol either alone or with midazolam. And it was looking at around 300 cases in ASA 1 or 2s. I guess many of our patients who come for the list are ASA 2s to 3s, but this does give us some information and some comfort, I guess, around safety of deep sedation and endoscopy. Interestingly, in Europe and in many parts of Australia, the actual drugs are given by the endoscopist or their assistant, or even a nurse or nurse practitioner, and a minority of patients in this study receive their drugs from an anaesthetist or intensivist. In terms of outcomes, the mortality was lower than for an elective GA at 0.005%. Major complications, including transient oxygen desaturation below 90% for less than 60 seconds, or less than 75% at all, was also very low. And a minor complication was present in around 0.3%. So reassuring in terms of use of propofol in endoscopy. I guess if you are having desaturations, one way to avoid that is by using high flow nasal oxygen. And this was a study from GI endoscopy in 2009 that looked at an improved number of events when you're just using 2 litres of nasal cannulae versus 60 litres of high flow oxygen, much fewer total events, principally less evidence of subclinical respiratory depression between 90 and 95, or hypoxia, as I've defined earlier, or severe hypoxia, or the need for manoeuvres to improve the airway. So we know that in patients that are having deep sedation, high flow nasal oxygen may improve those parameters. There's been a couple of joint publications between the College of Anaesthetists, the BSG, and the Joint Advisory Group on Endoscopy, and this is one that looks at cases that may be considered best for anaesthetic-led deep sedation. I've mentioned some of them already: resection, endobariatric procedures. I think if you're having large GI bleeds or foreign body retrieval, these are patients that would be have endotracheal intubation rather than deep sedation. And again, prolonged procedures, interventional endoscopy, and complex polypectomy. And some of the summary points I think are really germane to our own practice, that training in conscious sedation should be essential both for endoscopists, but also developing local training for anaesthetic trainees. And I think this is now part of the curriculum for trainees in anaesthesia to get familiar with deep sedation. And I know that Nehar and colleagues, Yuhin, also have many trainees who come to our Tuesday list, and I'm sure that's the case for the other lists. We do audit at our M&M meetings, and I think the collaboration between anaesthetics and GI endoscopy is only going to increase. So just a brief idea of what some therapeutic endoscopy could be. This is a patient with a dilated bile duct and gallbladder from a pancreatic mass that wasn't accessible for ERCP. At endoscopic ultrasound, we can see the common bile duct right next to the first part of the duodenum, with a portal vein just below. There's some biliary sludge just sat in the lower part of the bile duct, and there's a mass here in the head of the pancreas that's occluding the bile duct and causing obstruction. Instead of ERCP through the papilla, this hot axius, device can enter the CBD directly with a cauterized tip, so puncturing through into the bile duct. And then we can deploy a dumbbell flange stent that can allow drainage directly from the CBD above the tumour into the first part of the duodenum without having to traverse the mass with a stent that can reduce obstruction rate. So the flange deployment in the first part of the duodenum now just allows this bile to drain directly through and is suitable for patients who fail the RCP and may be due for palliation, chemotherapy, and improvement of symptoms. And it does improve jaundice with stenting. We can see now there's air in the biliary tree and the stent's in place. So things that were previously done with percutaneous or even surgery are now accessible endoscopically. And doing this with adequate sedation makes the whole thing much less stressful, not having to be a sedationist endoscopist at the same time. So just to finish, what about logistics and future options? We've got to think about the room setup depending on which type of endoscopy. And I'm very conscious that we're much further down the safety alphabet than anaesthetists. You've got the airway, breathing, circulation. You don't even get to GI till well further down the alphabet. We know that initial bronchoscopies from Gustav Kilian in the late 1800s has really changed. But I know that Steve's approach for bronchoscopy setup is probably quite different to our setup for ERCP, when there's a lot more kit in the room, including fluoroscopy and 2 or 3 screens. And often the anaesthetic machine and kit is at the foot end with the tubing either for high flow nasal oxygen or endotracheal intubation coming up beside and allowing us all better access to the patient. A couple of documents that might be interesting: the British Society of Gastroenterology guidelines on sedation in GI endoscopy, and also the Safe Sedation Standards and Guidance from 2013 from the Academy of Royal Colleges, and also a recent update looking at the need for capnography in those patients that are having more than conscious sedation. They're worth a read at your own leisure. I guess the opportunities for you as anaesthetists and for us as endoscopists is that we've got around 11 million rebuild of a therapeutic endoscopy suite, providing 3 rooms to meet the increased demands and safety. And we're really fortunate to have really started to develop a strong leadership team with Yuhin Min, Tony Lucas, and Nehar has done a lot of work with this, and I think he's taking on the sedation lead role from Henry Skin, and we're very grateful for their input and support. I think training in deep sedation is going to increase for your trainees. The use of capnography in endoscopy and use of high flow nasal oxygen are exciting developments, and I think it's important that we continue to consider the training and the role of anaesthetic associates, who I certainly value very highly. Just to finish before Steve talks to you, things I've learned from anaesthetists, I think really to manage expectations to the patients. Don't tell them they're just coming for a GA, because then they're terrified when you tell them they're going to have deep sedation, because that may have already failed in their eyes. Be courteous to each other, be prompt, on time and professional. And we think that teamwork's great fun. It's nice to work closely with another group of clinicians within the hospital, and we can learn from each other. The asterisk is because I've also been married to an anaesthetist for 30 years, and I've worked with anaesthetists professionally for around 30 years. And what I've also learned is 1 or 2 other things. When they say the team's great, what they might mean is you're not that special on your own. When they say, shall we brief, that always means, where the hell's your team and your kit? Why aren't you here? Is there a trainee? Do you think I'll make my spin class at 6 o'clock? Have we worked together before? I think so. Could you stop for a second? What have you cut now? Is that clock right? Do you have the Costa app? And finally, see you in a couple of weeks. I'm not doing that list again. And thanks for the opportunity to talk for you today.